So this is the opportunity to hear from industry and industry perspectives. Okay, Molly, so you're coming up straight away. Okay, so what we heard just now was a public sector perspective, and what we're going to do is have a session that starts to look at what, with whom, what has, who has, and where are the resources, okay? So I understand why people can't see the screen, right? Okay. So it's a test, isn't it, Ree? Which I've just singularly failed. Okay, so what we're going to do is start with some introductions, and then we're going to, I'm going to let each of the people introduce themselves, and then we're going to have some opening statements from each of them, and then we're going to have an interaction between us. So I'm very happy, because of the small numbers, for this to be as interactive as possible, so that everybody who's here gets the most out of it. So if I'm gonna start at the end. It's just random. So I'm going to start with over on the far end.
Hello.
Dean.
Thank you, Blitten. My name is Dean Andrews. I work in a company called InterSystems. If you're not familiar, InterSystems is a technology company. It has a data platform technology that is used very widely in healthcare around the world. My role in InterSystems is that I run a team that manages InterSystems' startup program and corporate venture fund. I have worked in high tech my entire career. I've worked in innovation initiatives in large companies like Microsoft, Amazon, and others, but also in smaller companies and startups. Very excited about startup innovation in industries in general, and have had the fortune of coming from kind of commercial endeavors and domains into healthcare. I've been working in healthcare tech for probably 8 years now, but very excited to be here, very excited to have this conversation.
Yeah, Molly, so you're sitting there, so yeah, please introduce yourself, yeah.
Okay, I guess this is on automatically. I'm Molly Schijven. I'm a professor of surgery in Amsterdam UMC. I'm also the lead for my university on digital health. I have a few side roles. It's a small group, but yeah. I'm board member for ZonMW, which is the largest health subsidiary organization of the Netherlands. I'm board member for Meander MC, which is a large peripheral hospital in Amersfoort, and I'm the former CMIO to our government. Yeah, that sums it up.
Hi everyone, my name is Tabi. I am with a global strategy consulting firm called McKinsey. Some of you might have heard of it. I'm an unusual consultant. I only joined the firm very late. I spent most of my life building businesses in the tech and consumer space, most recently in Silicon Valley. And I'm here to talk about the McKinsey perspective on what the health market may be moving forward.
Great. I'm Joanne Hackett. I work at a company called IQVIA. For those of you who are unfamiliar with IQVIA, we are the human data science company. So we have a lot of expertise in data, not just collecting it, cleaning it, curating it, and all of the other stuff that the last panel was talking about, but also doing clinical trials as well. I'm personally a geneticist, and I've been with the company leading anything to do with our health systems. And by that, people often forget that we do work with governments and hospitals, as well as payers and providers in a variety of different settings. It's not just with your traditional life science clients. So I was intrigued by the last panel, and hopefully we get to talk about a little bit of that side of the world as well. Thank you.
So fantastic. So all three global organizations, I'm proud to say, are members of the ECH Alliance. So for those of you who are here, this is a really great opportunity to hear experience and expertise and views from these three global businesses. But I'd be disappointed, okay, if this session is not a little controversial, because some of the things said in the first session, okay, we may not necessarily agree with, and there's nothing wrong with that. okay? Because part of what we have to do is, I like to say, speak truth to power. And also we have to be honest about healthcare. So that's just my managing expectations about what I would like to see out of this. So I'm going to start now when we're going to have the first 3 5-minute presentations and output. So Dean, lead us off, please.
Okay. I believe that healthcare is a very interesting industry related to innovation. I'd say that it is slower in innovating than other industries that I'm familiar with. I do want to say that it is not the case that I believe there is no innovation happening in healthcare. I think there is innovation happening in healthcare. I think there are many dedicated healthcare professionals in different stakeholders and different organizations that are innovating and doing amazing things. I think there are medical miracles that happen every day. However, I have seen, again, coming from kind of the consumer high tech and everything into healthcare, that it is slower to innovate than other industries and domains. I think the reason, from my perspective, is complex and multifaceted, but if I were to try to simplify it, I would say that the topmost issue is the risk aversion that's in healthcare. It's certainly understandable why there's risk aversion, but I believe, and to be a little controversial, that it's almost as if the risk aversion is used as an excuse to limit competition, and that competition is actually one of the driving factors of innovation in every industry. And so that's, I think, a key challenge here. I think there are ways forward, and I think there is a bridge between healthcare and technology that can foster faster innovation in healthcare. But I think let me stop there.
Okay. So we'll carry on with the industry side first, okay? So, yeah. So if you start.
Okay, so when Glenn and I talked, and I asked him, what do you expect me to bring? He said, like, 3 things, basically. Bring some numbers, challenge our current thinking, and bring a new perspective. So here goes. So since the 1960s, globally, we have added around 20 years on the average life expectancy, which is an amazing achievement, right? On the hindsight of this, of those 20 years added, less than half is actually living in good health. So what we have created is basically a lot of more years to live, but not necessarily in a format that we would appreciate today, being healthy individuals. Now, what does that mean for the future? For us, it is 3 things that are coming out of this. First of all, the definition of the health market is most probably about to change. Secondly, we believe that the consumer is becoming very, very savvy about that health begins before I become a patient. And thirdly, we believe this will lead to the development of new, very successful companies and enterprises moving forward. Let's start with the first element. So we see a trend that healthcare is only becoming one of the elements of the health market. The other elements, such as physical input, movement, everyday living, state of being, exposure to the elements, are all factors that influence our health. And there is a huge industry developing around these elements. This industry, we believe, will get to the size of the current healthcare industry, which is like a $12 trillion market. And why do we believe this? So first of all, there is the consumer. We know that the consumer is willing to shift his budgets, despite the cost of living crisis, more and more into products and services that will guarantee him a healthier lifestyle and a healthier being when we become older. This is number one. Number two, the price elasticity on goods that provide me a better health is very low. So there's a very attractive price point to those products. And thirdly, once people have built trust, there's a very high likelihood that they will stay very loyal to your company and to the products they offer. So this is the consumer side. And then on the emerging company side, so we believe that the next big company, so currently it's a chip maker, that's the most valuable company in the world. We believe the next big company will be the company that has cracked consumer health. So that takes the health market to the consumer, offering health services before becoming a patient. It might sound a little ambitious, but think about it. So of the 10 largest companies in the world, the majority of them are consumer companies. One of the largest industries is the healthcare industry. So it is very likely that the company that cracks those and bridges those two areas will be the future champion amongst the companies in this world. And I challenge all of you to, to think about it and venture into that space, which you have done.
Great. Okay, well, if we want to be provocative, I will have to start with saying we shouldn't have innovation in healthcare, right? We have a sickness service, not a healthcare service. So if we have a sickness service, let's treat sick people. And if we want to have healthcare, let's innovate in healthcare. It's very different. So you're talking about a preventative agenda. Nobody pays for prevention. The only time, probably in any of our lifetimes, we've seen anyone pay for prevention was COVID vaccines. Nobody pays for it. There's no repercussions to not take care of yourself, and therefore the healthcare service is supposed to provide you with healthcare. So you go because you're sick, right? None of us go to shoe stores and walk in there and ask to buy fridges. Doesn't work. You go to a shoe store to buy shoes. Why do we go to a sickness service for healthcare? It's kind of strange. So to me, if you want to be a little bit provocative, I don't think there should be innovation in sickness care. There should be an innovation in healthcare. And to your point, it is going to have to lie more with the consumer. We can't, we're definitely in an unsustainable place now where for far too long we've been allowing society as a whole to know that there's going to be a way to get out of trouble. Now, this is disclosing the fact that there are individuals who are genuinely sick. As I said, I'm a geneticist. I'm fully aware that there are things that cannot be helped. But for individuals who have chosen to make certain choices in their life to be unhealthy, why do they then expect us to innovate in a healthcare setting to be able to provide them with a better way of living? And who picks up that tab? Why are we not making society healthier? And if it's going to go back to the consumer, that's where we need to think about more innovation. I have never met a hospital CEO who said that the most pressing issue that they have is something to do with a new healthcare electronic system or a new way of ordering bandages. The most important thing they care about is clearing their car park. It's a business. It's in and out. It's patient flow. So if a hospital CEO is trying to clear their car park, where's the healthcare innovation coming from? Why do they care? They don't. Is there a faster way to get a patient in and out? It's because the patient is sick. So it's the sick care service that actually needs innovation in the sense of patient flow, which then ties into the healthcare service, which is how do we get access to treatments, medical devices, ways to monitor our health better so we don't get sick. Just putting it out there.
Okay, fantastic. So we've started to be honest for certain, and I'm going to hold off what the public sector angle is for a second, and just let the industry guys just kick this around. So why is innovation so slow in health? So I think somebody in the last panels talked about 16 and a half years. The last time I saw the random clinical trial to scale up of the recommendation from in an England source from Imperial was 19 years. So those of you who don't know me, I'm a healthcare lawyer. Okay, so my starting position is I think that's criminal. Okay, so I'll give you a specific example. So familiar hypercholesterolemia, which is a genetic high cholesterol. The random clinical trial is over 22 years ago, and it's a simple blood test, and it's a simple statin if the child has it. If they test the child, they invariably find a sibling. If they find the sibling, they invariably find one or both parents, and maybe one or more of the grandparents. And if they don't treat them, some of the children, very small number of children, die, and the parents and the older children will get heart disease. So 22 years later, only 2 European countries are screening children in school. Okay, and so there is no logical answer to that at all, other than it's a scandal, but actually we put up with it. And so part of the problem is about honesty, and it is about tackling those tough issues and getting it out there, because the trouble is that for the startups who are looking to do things, and I'm guessing, Dean, with you, a lot of the guys in the accelerators, or around the conference the last few days, if you talk to people, they run out of road. They run out of funding trying to talk to all of the hospitals or the commissioners of services, because they simply cannot get people to actually be buying sensible things. So can we just kick around what your experiences are, again, from your different backgrounds, around what can we do? Okay, so we know we've got a problem, but what can we do to accelerate this innovation, do we think?
I'll jump in and say, so agree with everything you just said there, Bledden, and that from my perspective, that the kind of standard operating procedure in healthcare, or our sickness service, as Joanne said, is that, you know, there are these established players. It is a business, and it's very difficult for many who work in their day-to-day jobs to try and invite innovation and new solutions, or spend the time to work on them themselves. Again, it's not, I don't want to paint too broad a brush, because of course there are medical professionals who are innovating, who are working on kind of startup things while they're doing their day jobs. I've seen that as well. But, you know, kind of a general term there. So then, and again, kind of fortunate from my position that I believe in healthcare, a lot of the innovation will be driven through startups. But as Bledden said, in my experience here, 3 years in InterSystems, that it is very challenging for startups to actually integrate into the existing workflows, the data streams, and so forth. And so that is part of my job, is to try to fix that element. So that is a key point. I believe that you know, some of the challenges I've heard with trying to incorporate startups, get them through pilots, get them past pilots into success, are that, of course, it's a time and resource element for providers and other organizations to kind of engage with startups. There are costs. Many startups fail, so that there's an idea of wasted time spent with startups. But I believe, based on my experience working kind of in innovation initiatives for many years, that we can fix all that, that we can get providers and other organizations to just tell us what would work for them, what are the costs that they can't cover, what is the limited time resource that they have, kind of lay out all the criteria that's needed to engage with innovative startup solutions. And then we, in partnership with others, can actually address and solve all of those issues, and then engage in startups innovating in healthcare. That's my kind of take.
Tabby, you want to add?
Happy to. So I think if what we're seeing is that the consumers, actually the early adopters, are out there, and if you build a health company that is not relying on the current healthcare system, but maybe focuses more on the consumer, you have a real chance. If you think about topics that are trending at the moment, longevity, micro habits, self-optimization, these are all indications that there is a growing base of consumers that is willing to invest into a change of behavior today, because they know that this will make them live healthier in the future. And with the goal to keep them outside of the patient care system. So I would encourage all the young founders to think about the consumer as your main source of revenue rather than the current healthcare system.
And you actually used the point that you made about genetic screening, because clearly this is not only near and dear to my heart as a geneticist, but I used to work at Genomics England. And for those of you unaware of the Genomics England's whole method and whole methodology and what it was trying to achieve, it was the first healthcare system based in the UK, the first healthcare pilot to be able to see whether or not screening individuals would reduce admissions, try to save lives, and do various things like that. The reason we were able to start that in the UK was because at the time our previous Prime Minister, I think there's 7 of them, joking aside, but several previous Prime Ministers ago, it was David Cameron, whose son had a rare disease, who died. So he was personally very interested in this, and also knew that if we could think about screening individuals before they got sick, that we would have a better chance of doing it. Of course the answer is yes. Of course we saved millions of pounds, and of course it was a very good thing, which is why the UK was one of the first countries free at the point of care to do genetic testing. So if you have a suspected rare disease in the UK today, everyone is offered a whole genome sequence free. And there are certain forms of cancer that are now being brought on board as well. This is 12 years in the making, which is criminal. It's absolutely criminal. There are certain conditions that you just have to test one gene. And we don't do this for newborn screening anywhere in the world, which is, again, kind of shocking. But it comes back to the point, which is prevention, right? Why don't we have these screening programs? It's fantastic that there's lots of these mobile buses that go around and that they look at children's hearts and do ECGs. What are you going to do with the data? It's like, you've got a heart defect. Great. Well, I hope you don't die in the soccer pitch, but have fun with that. It's just really strange that we're actually enabling people to know that there's a problem, and then kind of sitting back and thinking, please don't die during this this game, because that'll actually be a little bit, won't be good for the fans. It's just kind of strange. But again, who's paying for that? And ultimately, at the end of the day, we want the innovation to be happening in a way that we're going to see change. So again, when we talk about, it's great to see that healthcare professionals are doing more innovation, but ultimately, at the end of the day, I'm really sorry, I didn't spend 15 years in university to be able to go off and implement some sort of electronic medical record and be the CIO in the hospital. I don't think you want that from me, right? You want me in there actually doing your genetic testing. That's what I'm good at. So we actually put our healthcare professionals in a really awkward position. Right? They spend 15 years in university learning a skill. Then you say, oh, and by the way, do you mind doing some interoperability here with this app that we have? And there's also a really clever way for us to be able to monitor this person's blood pressure. Do you mind putting that on the list of things to do? I'm not going to do it. Right? Innovation's not going to happen because I'm not going to do it. Why am I not going to do it? I'm not going to be good at it. And it's not going to help me do my job any better. So we have put unrealistic expectations on the innovation agenda when we think about healthcare. So it's not that it's not happening. There's loads of innovation. We see these startups all the time. I'm sure, unfortunately, Dean, you have to watch them end up failing because they don't have a chance to get into these hospitals, scale, implement, and then grow because it's not on the list. Remember, the CEO's number one priority, clear the car park. It's not helping. It's not going to be prioritized.
So we have another clinician on the panel. So let's spice it up a bit. So I'm sure that you've probably got some different views. So what do you think?
That's a very broad question. What do you think? Now, in my opinion, when you talk about digital health innovation, it's not about innovation. It's about question articulation. Mm-hmm. Yeah. And what is the problem? And many people don't start with what is the problem. And I feel at this moment we should not really talk about innovation. We should try to address the problem. Yep. And the problem in the healthcare system, in my opinion, is that it is under too much stress. And stress can be a variety of things, but we cannot take care of our people if we are unable to take care of the people who have to lend care. Mm-hmm. And I think that is what we're seeing, a result of shortages. Waiting lists are piling up. We have shortage of money because we don't have enough people in the hospital that can sustainably provide care. throughout the system. And we are unable to onboard young professionals to basically go for the passion taking care of people, because they see all those things coming at them which they don't like. And that means we are asking for solidarity twice of the people who are working in the hospital. First, they go over their own limits, and the young people in the hospital say, I'm not going to do that. I'm going to go home at the end of my shift, which means that the patient that is there, and lots of things need to happen, the same boomer has to fulfill those tasks because the young people don't. And then you get anonymosity at the work floor that contributes to that level of stress. And in my opinion, it's not about innovating, it's about looking for solutions that are already there, but not well applied. And sometimes there's a little bit of space in terms of we cannot solve this with the materials or methods we already have, and then we need to look at innovation. And I think that's the key. And all those people knocking at my door, I have the next golden egg, they have not started thinking that way.
So that's so much I agree with what you're saying. So I think some people could be sitting out there, or if they heard what we were talking about, would thinking, God, we're being very negative. But actually, personally, I think that until the truth is exposed, until we talk about the real issues, we actually have no chance of moving forward, whether we call that innovation or progress or by whatever description we call it. So I have one wish for healthcare conferences, okay, that I come away and nobody talks about digital health. We just talk about health. Because if I said to you, put your hand up if you have a banking app on your phone, how many of you have banking apps on your phone? Hands up. Right. Not one of you doesn't, okay? But we still, healthcare still thinks that digital health is some form of innovation, whereas every other industry thinks just digital is the way we do it. That we don't talk about digital banking, do we? You know? So there's a requirement for honesty. So in the UK election at the moment, okay, all sorts of parties promising we're going to have 10,000 new doctors, 15,000 new doctors, whatever it is. And you're like, well, how long does it take to train a doctor? Like, this is nonsense to be talking about and giving the expectation both to the staff and to the public that this is what they're going to do. And the idea that we don't have healthcare planning for workforce that needs to be 10 to 15 years in delivery, it's a nonsense. But until we start talking about it, and until citizens start saying this is wrong, we're not putting up with this with whichever government it is, so that actually we tackle the burden and the burnout of clinical staff. But we also deploy then some of the solutions. So I absolutely agree with you with saying what we just want to see healthcare do is adopt the last century's technology, let alone current technology.
Exactly, and it may sound a bit strange for me because I'm chair on digital health, but the first thing I always do is try to get it into people's minds what I just said. We have a sick system, and before we can take care of people who are still healthy and becoming sick, we need to solve the sickness in our system. And I think that's not well enough in the agenda, and you're exactly right, we're not going to have more healthcare professionals.
But I think that picking up the point that Joanne was making about illness systems, okay, a lot of the public don't understand that. They don't understand that our healthcare system is really an illness system. And actually that every time a politician puts money to prevention, okay, halfway through the electoral cycle, they're going, oh, we've got a long waiting list. They take the money away from public health and from prevention, and it's redeployed to frontline services, and public health and prevention just goes back down the priority list again. So we've just got to do something about this. But I'm quite interested in one of the things we just talked about, which was the consumer, okay, against the citizen. So I don't know whether I feel like I'm a consumer, okay, in the sense when I talk about healthcare, because part of that honesty is that I got diagnosed with late onset asthma, okay, and I was very ill for a few weeks, and they thought I had all sorts of heart problems, and I had all sorts of tests. And then since then, my asthma is totally in control. A big problem for me is when it's very damp in the winter, and also I'm a big cyclist, so I have to be really careful for the first hour when I ride that I don't push myself into the red zone too much. So I've got a battery of stuff that I use on the bike, and I'm measuring my heart rate, and I'm riding to my heart rate. Okay. And my friends just, they just don't care. They just go off like as fast as hell, and I'm struggling for that first hour. But my point is that I just buy that because I like cycling, and I want to cycle the best way I can. And for asthma, I follow readings. And then I got diagnosed a couple of years ago with type 2 diabetes, which was entirely my fault. I was just eating badly. And so I reversed that, but I used quite a bit of technology, and I used Libre 2 myself because I was thinking, right, I just need to watch what I'm doing. And when I was cycling, I was having sugar lows, so I thought, I need to get to that earlier. And for Tabby's, one of his partners, Tobias, is hacking himself. So he discovered in doing that he's got FH, and he's got a lipid disorder. So I'm not sure that I see myself as a consumer that way. I just see myself as a person, and I'm thinking, what tech is out there that I can use to improve my lifestyle and get a better night's sleep, or that I can be more active. So I think this idea of is it a consumer? So if we're actually pushing this out and we're trying to see more innovation, do we characterize it as consumer, or should we just be talking about people and people's health and well-being, and how do we do that? And then they decide what the tools are they do, and whether they're buying stuff. So the NHS doesn't give me type 2 diabetic, the Libre 2. So I bought it. So I go to see my GP when I'm for a routine appointment, and I start showing her the data, and she goes, "How have you got that? That's not on your medical record." I went, "Well, I just bought it. And I've been using it. I don't use it all the time, but I use it when I think I need to. So when I come away to a conference, I eat badly again, because I often don't eat, miss meals. So I then need to be tracking it and seeing what's happening. So have you got a view on that, or am I being over precious about how I label it as a consumer or as a person?
But why is it important?
Well, I'm just because in this context we're talking about is it a consumer? And in some, in European context, sometimes that's a dirty word, because the idea that healthcare is a consumer
we are all consumers of healthcare.
Well, yeah, okay. Well, that's the answer then. You don't think it matters. Yeah, you don't think it matters.
Yeah, maybe to your point. So people become consumers when they find an offer that they find interesting and they're willing to spend money for it.
Okay.
So I think the only perspective I can offer on this one is that the health journey begins more and more way before people turn into patients. So you have this group of people who are curious about improving their performance, right? They will go to doctors, they will invest into apps that enhance their performance. Then you have people who are, or enhance well-being. Let's start with well-being. Then the next is the people who have a specific goal in mind. They want to be a better cyclist. They want to be a better in their job, that invest over and above to get diagnosis on a very medical professional level, genome testing and so forth. They spend a lot of money on it, but they're still not patients, right? They just want to know what they need to do to be better themselves. And then you have those people who know that they're predisposed with diseases, that want to do all they can to eliminate the risk of becoming the patient. And only then you have the people who are actually patients, who have a condition, who move into the healthcare system. So there's a whole group of people that are beginning to invest into health before becoming patients, and they're people.
And the only thing I would add to that is, bizarrely enough, anyone who has private health insurance, they have to self-manage. However, you have to make your own appointments. I'm not sure if it's the same in every country, but in the UK, you have to make your own appointments. You get a variety of different choices to make. Here's a couple of different clinicians. You can pick the one you want. And then you've got to call them and make the appointment yourself. And we pay for that. It's fantastic, right? Which is kind of funny. We're paid to do the thing that someone should be doing for us, whereas if it's publicly funded, we do everything for the citizen. So, and I'm not saying that it has to be one of these situations where everything is free or paid for, but we should also be thinking about the individuals who need public health care in a slightly different way. Why do we allow people to come into A&E for an ingrown toenail? It's kind of ridiculous. Why don't we use pharmacies more? These are everywhere, right? So there's different ways. To me, the innovation in either sickness care or health care, depending on how you look at it, what's the infrastructure we currently have that we can tap into, right? The reason why people aren't training to be a pharmacist anymore, they're tired of giving people plasters. How boring is that, right? These are highly qualified individuals. They want to be doing really interesting things. And again, it's not all about genetics, but why can't they do pharmacogenomics in the pharmacy? You should not take this drug, it will kill you. Thank you. That would be fantastic to know. We have pharmacies everywhere, right? This is a 10-second test. It's just very strange. So, I don't know, I would probably add to the fact that the group of individuals who are going to self-serve are probably the individuals who've had to self-serve because they probably have private health care, or maybe they're a bit more interested and have had to learn how to manage themselves, much more so than just relying on the fact that someone will sort me out. And we've allowed that line of someone sorting me out to be blurred more and more and more. And, you know, being in the UK, I'm sure you've read the newspapers as well as I have, we've got healthcare practitioners who refuse to discharge patients because the patient has told them, I don't have any heating in my flat. Okay, that's tragic. It really is tragic. It's still a hospital bed that somebody having a heart attack is not going to get. It's just really strange. So we don't have clear mechanisms, again, for that churn when it comes to a hospital. Also, why are these people in the hospital? That piece of how we actually manage sickness is the thing that I think we need more innovation in.
I agree with a lot of that, especially the use of pharmacies and things like that. But at the risk of infecting yet another panel at Health Europe with the topic of generative AI, I do believe, I'm one of those that does believe that generative AI is this milestone in all of our lives, like the creation of the internet and mobile devices and so forth. And I believe right now that generative AI is one of these technologies which will have it be that consumers, all of us being patients, will demand that generative AI technology is leveraged in healthcare, and that they will move toward and choose those organizations that are leveraging that, because they want to have the ambient conversations between the physician and the patient where the clinicians are focused on them and speaking with them rather than working on a workstation. And they want to be able to chat with their own health record and learn things about themselves that they, in their health, that they didn't know. And they will choose those entities that are leveraging that. And then the last little point is that I'm very hopeful in all this, because then I also believe that just implementing generative AI technology in healthcare will actually unlock the data for other solutions that aren't necessarily generative AI, and it will be one of the fulcrums that actually brings more innovation into healthcare.
So that's moving us into a conversation, I think, about data. So let's go there. Because we've got consumer data from everything wearables that we have. We've got all sorts of data sitting inside hospital systems, sitting inside primary care practices, and access to data, and we've touched on a little bit about the European health data space. So, and then in the earlier panel before us, one of their comments was about the value of data. So given that this predominantly we're talking about from an industry perspective, I think we've got to talk about the elephant in the room, which might be that value of data and the business model around it. So let's start with AI and not deep dive and infect the conversation in the sense that there's lots of benefits that around this conference you could have heard about. But one of the key things that AI goes nowhere unless it gets access to health data. So the European health data space is the European answer to trying to ensure that the health data is made available. But what do we think? Because I mean, this is your core business in IQVIA, isn't it? So what's your sort of view on the health data market at the moment?
Yeah, so it's really strange because a lot of people think data is valuable, and the amount of times I've had, whether it's startups or other companies come and say, oh, we've got this great biobank, and do you think that you'd be able to either, sometimes they want us to buy it from them, or maybe, whatnot, commercialize it in some way, shape, or form. And it's really, really hard when you have to turn to this person and say, you have a hideous child. Right? Nobody wants to know that their baby is ugly. And it is always, I've never seen a cute baby yet. They are always hideous because you have 1,000 data points. Well done, you. It means nothing. No one's going to buy it. It's not diverse enough. It's not deep enough. There is nothing you're going to get in there that are any sort of insight. So well done. Carry on. When you have 100,000 data points, 100 million data points, and you've got representation from 14 different ethnicities, come and see me, somebody might buy it. It's really terrible, but that's honestly where it is. So healthcare data, bizarrely enough, if you've seen everything about my data, it means nothing, right? You're not going to get any sort of insights into that. So, and in this whole entire room, if every single one of us shared everything we had, you're still not going to be able to get any sort of insights. No one company and no one country can do this. It really has to be about opening it up globally in order to make these insights. So the value of data, I know everybody's, oh, it's the new oil. No, it's absolutely not. It's definitely not the new oil. It's definitely not going to be useful for anything until people start allowing it to be used. And again, I'm 172 centimeters. Does anybody really need to know that? Probably not. You might need to know it for a dosing of a drug. Fantastic. But if you don't need to know the 172 centimeters, take it out, right? Do you need my address? Probably not. If you need to know the postcode because you want to look at carbon emissions to see whether or not that's affecting asthma or something like that, fine. But you don't need to know probably the 172 centimeters and the postcode. So it's all about what actual components of the data do we need. And the thing is, everyone is terrified. The thing with health data and the reason why we've not made as much progress, because each one of us has something that we don't want to share, right? Do you drink too much alcohol? Do you not want to tell someone about that? Maybe. Unfortunately, Uber knows that about you. So why not? Well, I mean, it doesn't really matter. Somebody knows this about you already. So every single person back in the day who had a Facebook account, you don't care about your personal data if you've got a Facebook account. So why do we make the health piece so strange? It's really, really very odd. So the value of data is not actually knowing every single thing about me and every single thing about everybody else in this room. It's being able to make the inferences and be able to predict. And for health systems as a whole, predictive mechanisms are much more interesting than actually understanding that 22% of the people coming through the front door live in a particular geography and they happen to have type 2 diabetes because they're really close to a particular donut shop. That's good information. It's not going to change the health service. So to me, it's all about the right pieces of information for the questions that you're asking about, and that is our
use
data.
cases, isn't it? It's use case specific.
Use case specific.
So what do other people think about the data points we just kicking around? Any views?
Yeah, if we look at which industries are currently looking into entering the health market, it is those industries that have a vast amount of access to people's data, and who don't have it on a one-off basis, but on a continuous basis, which allows them to deduct analyses on people's behavior. So what are those industries? A lot in consumer, so retailers.
Yeah.
People every week spend time at retailers, give them ample amount
where
of
your
data.
wine bill becomes relevant, doesn't it?
Yeah, and very concretely, the largest primary care provider in Switzerland is a retailer today, just as an example. And that's just the start. So what else? We have telcos who have a lot of data, mobility data. We have the obvious tech companies. Most of the people on this panel, not you, a very mechanic, are wearing a wearable device, right? But this is just one element of a whole ecosystem of data collection, right? So if we look at the, again, industries that are moving into the health space, it's exactly those who due to their contact with a lot of people, can collect a vast amount of data over a long period of time and have the freedom to then deduct which data is relevant and which is not.
Excellent point, and I think we all fall into the trap of using health data as a description, when what we should be talking about is just data and different forms of data. Clinical data is one, the pharmaceutical data is another set of data, isn't it really? And then we look at different types of data. So you were talking about telecommunications, you could be talking about any of the consumer products that are wearables, but we could be talking about social data. So the sort of new areas that someone like Wellcome Trust is looking at in order to try and understand what impact could that have on well-being and prevention. But I'm just going to come back to one point. So I spent 6 years on the commercial board of a major hospital in the UK. So I do take issue with data is always worthless, okay, for a second, because there are some types of data sets. So in the context of a hospital where you've got a leading clinician that has been collecting data for 20 years around a particular condition, that data is valuable. And what I have found so far is that industry is actually not recognizing that, so that they want access to the data. They'll pay for the curation of the data and its inputting and cleaning it up, but they're not prepared to share the commercial value they drive from picking up a product or developing a better service or a better scanner. And I actually think that the health system should share in that. I'm not saying what that share is, but I'm saying I think there's real commercial value there that should be shared with the health systems, because that valuable data is coming out of the provision of healthcare services.
Yeah, and I would agree with that completely. But the only thing I would say is, I'm not sure which hospital you're on, doesn't really matter, but one of the great examples in the UK is the work that DeepMind was doing at the Institute of Ophthalmology at UCL, the University College London. That algorithm that they developed was amazing. It was shared back with the institution. It's not rolled out anywhere else in the world because guess what? It wasn't ethnically diverse enough. So we didn't, it wasn't enough women to men, it wasn't enough children. So fantastic data set, very, very useful, snapshot in time. If I was, GSK or a large pharma company, I wouldn't pay for it either. No disrespect.
Yeah. So
it's a one shot, right?
So the data's not fit for purpose, is it? So
no, and that's why, again, it goes back to it is a hideous child because it's only one snapshot of it. Now, if, for example, there was some way to be able to take that data set, the data set from the Netherlands, somewhere from Spain, and combine it together, if industry could somehow wrangle that and do it, of course they'll pay for it, and then you can share that back. But it's very rare that health systems globally will share. It's just really quite unfortunate. So that's where, to me, the value is that it has to be coming from different sources.
Now, to me, it's not about data, it's about value.
Failure?
Value.
Oh, value,
And we
sorry.
should talk about value, not about data. Because the more data you gather, there will always be a portion significance. The larger it grows, the more likely that you have a significant outcome. That's just the rule of numbers. And what we hear here is industry noise. Generative AI is industry noise. If you put it on a Gartner cycle, Gartner itself says it's reflective of industry noise. It should not be about generative AI per se. It should be about finding value in numbers and how to do that well.
Yeah, I agree with that.
And that discussion is not on the stages. It's about industry presenting the next model of generative AI. You can, of course, convince a lot of people, and yes, it can be useful, but I'm totally missing the discussion on what's the value in the data and how to find the true value.
And I think, though, that there are very tech-savvy clinicians who are using generative AI, who are undertaking the sort of research evaluation to try and find that value. I mean, yesterday we're
But let me tell you, there's just been a large study, and we had radiologists looking at a picture, and if they agree on 80%, they say that's the diagnosis. Now, those school professionals who were in there for years, they were given the outcome of an AI model on purposely skewed outcome. What happened? 80% of those clinicians shifted their own mind. They were right, but the algorithm told them, you may be wrong, and what does the human mind do? The computer will be right. And those type of issues we need to solve first. Can you rely on something, and when do you know you can rely on something before you can draw conclusions on it? Because if you do, you're responsible. And if you're blind, no one can accuse you of being wrong. But if you're not blind, then you have a problem. And it's not about technology, it's not about AI, it's about the discussion, when do we feel or when do we agree that we can use a model, or what is the boundary of risk we accept? Those discussions need to come first.
And what's your solution for that? So how do you do that?
To start those discussions.
Right, okay. So that I don't have a problem with anything you've said there. I sort of start from the fact that, you know, what do lawyers do? We manage risk, okay? Different types of risk for clients all the time. And you're saying to them, okay, if you do this, you know, what's the level of risk? Healthcare professionals, to my mind, manage risk. Okay, they often don't admit that that's what they do, but the first time a HIV patient presented, that they were treated and they went through a whole series of treatments before they realized we've never seen this before. That's managing risk in a different way. So I think that it's what degree of confidence do you require? What degree of risk are you prepared to do? Yesterday, Dean and I were at a breakfast where someone from Google said that, you know, healthcare professionals, when they qualify, their pass rate is 60, I think it was, okay? And the AI is already operating at 90%. And they were just saying, so if you look at the question in that sense, your confidence levels change.
I absolutely agree, but can you sue the AI algorithm? Probably not. Can you sue the doctor or the nurse? You can. So we need to agree upon what's acceptable level of risk, and how can we rely on tools that help us, and what's the boundary around that? And before we have solved that question, we're still in a let me say it otherwise, we cannot put more AI algorithms into the lake, because that won't help us if we do not solve what the dike should be.
The other thing just to say about how we allow our healthcare professionals to pass 60% of the time. How many of you have flown with a pilot who didn't pass his exam? Just saying. They can't qualify. So just saying, we get on airplanes because it's 100% success rate, and we go into medical professionals at 60%. Well, it's kind of strange, right?
Yeah, or another way of saying it, okay, is that who's got a satellite television at home? So everyone's got a black box. Who understands how the black box works? Who's interested in understanding how the black box works? Or more to the point, who's interested or understands how electricity flows, or how the nuclear reactor works? We've got to the stage where, as a society, we have confidence in the regulatory system and the providers, and we don't need to know. I mean, what I think we've got to get to with technology in healthcare is that we have that same confidence in the regulatory systems, in the people who build them, in the processes that they go through. So actually, we're not talking about, oh, I don't think that's accurate, or I don't think it's misdiagnosing or whatever. But I also start from a slightly different perspective, which is, and you know, there are times when I'm quite bullshit, okay, about healthcare. So you probably need to understand why. So my first child died, okay, in the operating theatre, and it was certainly negligent, okay. But that did my wife no favors, okay. She's in pieces. I'm not interested in suing the doctor. I'm interested in trying to move past what is a tragedy in my life. And I'm angry that 35 years later, the same mistakes are being made in the UK, and we've had 3 public inquiries about maternity services, and we failed to learn. And the reason I'm doing this is I'm not looking for sympathy or anything, but I'm saying that healthcare systems do harm all the time. And they run risk, just like the no screening. So I don't want to see technology judged by a higher bar than normal clinical services, because the systems accept all of these things happening and without changing things, and then hold technology to a higher standard, because that makes no sense, particularly when that technology can solve some real problems about burnout for clinicians, about actually changing the way pathways are designed, changing the way that we interact with a health service. So we We de-skill some of the things. We move them from consultants to junior doctors to primary care to pharmacies, which is what we're starting to talk about, or even accepting that some things can be managed perfectly well by consumer goods. So I just think that this is about honesty again, about reality. So I'd like to see us try and do that. And I think that, you know, Jana's sitting over there, and she hasn't joined us for a second, but the Health Foundation is doing some fantastic work about women's health and exposing the truth. And I have to say, I'm embarrassed by the fact I didn't understand that how much discrimination there was in healthcare services against women. And there's been a couple of panels in this conference about trying to address that. And a lot of that, again, is data-driven. And what data, and the fact that all the clinical trials data was originally on men, and then even the mice were male mice and not female mice, and all of that. So there's a lot to do. But thinking about what we've just been talking about, what's the solution to some of this? How do we move forward constructively? So one of the words that a couple of you used was collaboration, okay, and collaboration across sectors and things. So anybody have any thoughts on how we do that? How do we work together better? Whether it's more hospitals. I mean, for the ECH Alliance, I've had this dream of a hospital club where I have linked cancer hospitals across the world, children's hospitals. Strange is that a lot of clinicians who go to professional conferences where they're talking to each other, they exchange data, but it's individual to individuals. It's not actually the organization and around. Not true? So how many do you share with?
Depends on the research question, but on the research question, the hospitals do share data.
Yeah, I'm not talking about research, okay? So I'm talking
That's
about...
the way how people adapt their guidelines in their practice. Right,
but I'm saying that start with, why are the outcomes different? So if you have outcome data, so if you have breast cancer...
Yeah, well, that's a very complex question. It's about volume norms. It's about correct application of guidelines. It's about doing research to improve the guidelines. And outcomes will always be different because people are not the same.
But you can't start that research or start that questions unless you share, unless you actually... Right, so law firms do it, okay? So actually we exchange outcomes. Okay, I'm going to different sort of thing. They exchange outcomes. Why? Because we're trying to improve things. And the starting point is, okay, your outcomes are different to ours. Why? Okay, and what I'm saying is, unless you have that operating on large scale, which is what a number of you were saying about large scale data, and if we're not doing it across border, so the simple person in me thinks, if the breast cancer outcomes are materially different between London and Newcastle, why? And then why are they different between London and Newcastle and Paris or Amsterdam or somewhere else? And I'm saying the opportunity going forward is to learn from this type of data as well as all the other sources. But we only start doing that if we collaborate.
I believe that's what we do. The thing is that people coming in the healthcare system are not similar in different settings. Maybe due to screening guidelines, maybe due to so the people may be different coming in. And also protocols may vary between hospitals. And the only way to find out what's the best way forward is indeed to share outcomes, and that's what we do. Then still there are discussions of people not applying the guidelines correctly or not being open to mature guidelines, but that's
and so Jana, yes.
Yeah, I didn't know I was going to come up earlier. Can I jump in? I'm going to jump in.
Yeah, by all means do.
A few things that I would love to comment on, and I'm just going to go back to the very beginning and say, we haven't talked about the fact that I'm about to go off stage. There we go. That we actually have a system that's completely broken and unsustainable from a cost perspective. And if you look at why that is, we actually have what we call in the U.S. a majority of people who are excluded from healthcare for a variety of reasons. If you look at
Other than health behavior, the factors that impact somebody's outcomes in healthcare, they have to do with social risk. They have to do with inequities. That's what leads to the outcomes disparities that we see. That's why we need diversity in data. So we have a huge upstream problem before we could ever get to prevention. Affluent people can think preventively. Everyone else is just left out and sick. So I think that one of the reasons we can't get to innovation in healthcare is because, and I really believe in competition, really believe in making money. Everybody has to sell a product or something. But upstream of that, we have a really big problem that we could deal with collaboratively. And it's around health disparities. And there's a huge value, like ROI, actual money, in addressing this problem. So I think if we could get industry to think about this, not just from a product perspective, but upstream from a cost savings perspective. There's a lot of money to be made in actually saving money. So I think that's what we need to be doing in healthcare. And that collaborative, I'll call it cooperation approach, where competitors can agree that this problem is worth addressing together, that there is money in it. I just don't think there's enough sustained investment in that problem. So what I focus on at Health Foundation, and I know there's actually a charity in the UK that's HLTH Foundation. I'm Health Foundation, so we focus on health inequities and disparities in healthcare, and one of the ways that I'm really hoping we can get private industry to invest, and that is to think about the fact that we haven't really defined this problem well, and that we need to get around the understanding that we have a perfect solution in technology for some things, including burnout, and that solution is really built into what technology does best. Technology is good at a couple of things: personalization, delivering on access, and delivering on better decisions, and then learning about those so we can just complete the cycle again. So I'm hoping that we can get to better, faster innovation in healthcare with sustained collaborative, cross-sector collaborations in a reframe of the problem there, where we understand that we're not actually using technology for the purposes to which it is best suited. And if we can go at that, and this is what I'm working on with a whole group of industry folks and government, et cetera, and we're tiny, so we're just starting. But thinking about what is a practice of digital health equity? What does that really look like in the field? So I'm going to start with that, the cooperation idea that we should be working together in industry, but across sectors as well, and to be thinking about disparities and upstream inequities like food security or housing insecurity. Those are things, if we could identify them, we could be better addressing them. The other thing is, I think when you think about personalization, immediately the mind goes to that's niche, and this is what we have: point solutions that are very meant to address a very niche population. But technology can do way more than that. So one of our recommendations, and just this week we actually introduced what looks like a very simple set of recommendations for practicing tequity. And one of those is to think about your population, but to work cooperatively, even with other departments, even with other agencies, to think about potential uses for data, for diversity of data, and so that when you come out with a solution, it can be easily scaled or potentially replicated. Personalization doesn't mean I'm collecting this, it means I'm designing for this, so.
We call it precision public health. Right, you don't know what's precise for one until you know what is basically an average of many.
So the plug, I think, for health and all the work that you've been doing with the foundation is they need more industry support, more people to put their shoulder to the wheel, as well as having the wider community of all stakeholders to help, and then promote those guidelines so that people are aware that they exist and right. Can refine them, because, as you said, it's work in progress, isn't it? And you don't have all the answers, but this is a great example of actually where all the stakeholder groups can come together and try and solve a problem that's very real.
Yeah, I really believe in public-private partnerships. I think charities are one great way to do them, and to bring people together around a model like that that can get us thinking in bigger ways about making money on the way to making money, and if you know what I mean. And I think that there's and doing the right thing. I mean, we're the one industry that claims that we're going to help people, that we are going to make people better, and I think we could get to prevention. If we could cut out some of the inequities, and then we get to outcomes disparities and we reduce disparities, so many more people will be able to think about prevention.
And we talk about societal good, but I always think that there's a self-interest here, you know. Each one of us in our lifetime, whether we like it or not, is going to be a patient. You know, our mum and dad are going to be patients. We're going to be carers invariably for that. And then our children, and we want to see them live the best lives that they can live in terms of their healthcare. So we're all vested in this working. So that's why it's a no-brainer for me that we actually need to work together more, but on a fair basis. And that's where I think there are some difficult stuff. But we crack it by being open and having adult conversations about some of these challenges, I think. So is there anyone in the audience who wants to jump in, ask us a question, thoroughly disagree with anything I've said? I'm sure you won't disagree with the panel because they're much more knowledgeable. John?
I've got just one comment, which I guess is also a question. I wonder whether in this entire debate, to pick up Janet's last point, we should go even more narrowly into health literacy. Yeah. I've noticed you all kind of, say that we're using the wrong terms and language in many cases. Healthcare is really sick care. Well, let's start calling it sick care. The etymology of a lot of words we use, patient means sufferer, which means you're really into healthcare. Hospital has a root of word hospitality, and yet it's nothing like a hotel. So maybe we need to think about the language we use in the first place, so we can start to get these exchanges going on the same basis. Even a word like data or digital or innovation, the first question is, what do we mean by that in the first place? And then I think we can start to have a debate. So one thing I'd advocate for example, you've all used electronic health record. I mean, all three words are somewhat problematic. But electronic was 30 years old. At best it's digital. You probably drop that word altogether. The middle word, medical, again, connotes sick care. So again, let's drop that. Why don't we call it the thriving record? Why don't we just do that? TR, and that's it. That's the new word. We advocate for that, for example, and then make people literate around that. So, just a thought.
Yeah. So I think interestingly, 2 or 3 times in the conversation I had in my head, digital literacy, health literacy, and again on our sort of wish list. So some of the work that we did around the European health data space, continually coming up was one, digital literacy, no digital exclusion, which is a real problem, which is to health equity anyway. But then it was, so this collaboration, for example. So back to my example earlier where I talked about banking and banking apps. Okay, the law in Europe is that essentially if you're a victim of fraud, provided you haven't given you a password or done something other really stupid, the bank has to put the money back into your account. Okay, so the financial services market in Europe is incentivized to build digital literacy. So in the United Kingdom, the example I'm giving you is Barclays Bank, who have something called Barclays Eagles, which is a whole digital platform that is throwing out content, okay, to their customer base. And it started off around fraud. How do you recognize fraud? And I bet you that there's not one of you here whose bank isn't doing something like that to you on a regular basis. Watch this scam, this is the latest thing. And then what Barclays Eagles started to do was to drop other content in. So they first started around their business customers, so saying it was about innovation, and it was come to this, click on this, whatever. And then we had a conversation with Barclays Eagles, and we said, why didn't you put health content through it? And we're having a conversation, and I thought, actually, digital literacy, why isn't healthcare systems having a collaboration with the financial services industry? Because they've already got the platform. They already know how to do this. They've worked out how to do this and start driving health content through it. And it wouldn't cost the health systems any money, really, because it would just be an added value service for the financial services. So I think we need to sort of think wider around how we can solve this without adding cost to healthcare systems.
But I think the most vulnerable people are the ones who are not in the electronic highways. And I think pushing content to try to reach them via channels they don't use is also a bit tricky. So I think, at least for my hospital, we try to have a keen eye on people who are not digitally savvy and don't want to be. And the same thing goes, I guess, we talk a lot about prevention, staying healthy, but most people don't give a fuck until they get sick. And I have lots of people who are scheduled for appointments, they don't show up because they have something better to do, or they feel like, and that's just the human mind, I guess. And I think that's, before I studied medicine, I studied health sciences, so that was one of the biggest problems. Like, we are very much into our own mindset, and we are into prevention and tracking and all those kinds of things, but most people don't give a
I think there's one thing that comes to mind is that people's health behaviors follow the health behaviors of the people around them. I think it's, the 5 people around you pretty much predict how you will be. So I think culturally we could do a lot more to make it possible for people to care about, or even if they don't really care, they're just sort of naturally engaging in health. If I don't have any terrible food options to choose from, then I'm hungry. I'm going to eat what's there. That's what the pediatrician used to say. Don't worry if your kids don't eat, because they'll get hungry. So, they'll eventually eat what you have. So I think that's one thing. And then I forget your other point now I wanted to comment on. I don't know. I'll say I think it's on us, though, to bring information to people, but a lot of people, you're right, they're not looking for those things, and we don't have the information. I spoke to it. I had a doctor in a webinar about a year ago who said he was treating a patient for about 3 years before he found out that this patient was homeless. This is a patient with a diagnosis, so we just have so many other issues aside from getting out basic data, and making it.
I really think most people are not interested in making the right choices for them. They are into convenience, into fast things that are pleasurable in the short term. And it's incredibly difficult. And I fully agree with you. If the people surrounding persons like that are helping, then you have a chance. But it is part of society that people who are in the lower health echelons flock together. And unless you have schools where there's no soda but there's water, and they have no choice, basically.
Well, societally, we've opted in to give, we've decided that it's not as important, I believe, even if it's a passive decision, it's there. We've decided that people who are less privileged will remain that way, and we won't give them good options.
I think I'm quite more positive on this, because picking up your point about digital exclusion, and I absolutely understand that, okay, but probably all of us have got kids, okay, and they give their data away for free in return for a service. So their attitude to it is totally different to mine, where I'm not on Facebook and I don't really like being on LinkedIn, and I'm truthfully, but it's just a business tool. But my son is just totally relaxed, and I think that the young generation, they don't care because they're not ill, okay, and it only starts to matter for a lot of them later in their life. But in contrast, before you arrived, I was showing some slides about innovation. Okay, one of the slides was from a sport, it happens to be rugby, and where the Welsh Rugby Union have created a curricula, okay, for primary school children about diet and exercise. So they took all of the professional coaches, the nutritionists that use for the professional players, and created this curriculum. Now, for them, the reason for that is that they're trying to get more people playing the game. They're trying to make their game sustainable because there's reduction in playing numbers. But what started to happen, okay, when we're talking to some of the schools, was that the teachers were becoming aware that the kids were going home and they were talking to their parents and their grandparents and saying, you should stop smoking, and you don't eat enough, and you don't go out enough. And they were saying, I want you around. I want you to be there for the next 25 years or however many years it was. So I think there are ways about the behavioral science that we can use and tackle some of these problems. And we won't, they'll take generations.
I totally agree. And that's, part of my chair is on serious gaming, which should not be too serious because then it's PDF behind glass usually, and that doesn't work. But how to tap into innate behavior that people enjoy. But the problem is, what is satisfying most of the time is bad for you. So, yeah, how to make water nicer than cola.
Yeah.
So that really is a difficult thing to solve. And, you know, I sometimes I ask the question, why do people feed virtual chickens in Farmville at night? Why do they put the alarm clock for it? Many women do.
Right.
If we can understand why that's happening, then you may have a key to drive behavior.
We have a question, yes.
Well, from the younger generation, when you were speaking about the black box and the television, I think many people of my age, they don't have a television.
Yes, because you use a tablet. Yeah.
I have a question for you all, because we were speaking about people who want to invest in health before they get in touch with healthcare. But it might feel like a privilege to me to speak like this, because looking back at the topic of the discussion, digital health innovation, how do you look at the role of digital health innovation in relation to the inequality nowadays in society and public health? Like, is health the new inequality indicator, and if yes, how can we change that compared to digital health innovation?
More than about 1 minute, right?
Well, I have a narrow view on this because it's my focus, but I think that focusing on how to leverage digital innovation for the most people. In the US, patient groups will say nothing about us without us. So I think that inclusion piece, but also just in industry, making sure that we're thinking of all the things you mentioned, like health literacy, digital literacy, cultural concordance of care. Those things can be built in because we have technology. It can just be built to do that. And then, of course, with humans intervening. Like I'm thinking of an agency I'm aware of that does this kind of culturally competent design of digital technology. Health Foundation actually ran a case study competition last year in digital health equity and learned so much about what works in this realm. And it really is, it's the design has to be right. You can overcome also disparities and inequities when you think about how you distribute your technology. Is it even cost effective? You know, and then when you think about digital literacy, you could use digital navigators. They're low cost. It's a community-based resource. And also, when you were mentioning burnout, I think there's a real opportunity to decrease burnout for physicians and nurses by thinking about how we could train paraprofessionals and even family caregivers and equipping them with digital tools so that they can be more independent. And that there's an access thing there too. I mean, access is so much easier with digital, but it does have to be designed and distributed for everybody's use. So I think there are lots of ways to do this.
One point data point I can share with you on that question is, interestingly enough, when it comes to perceived health, higher income socio-demographics have a lower perceived health than middle and lower income demographics.
The worried well.
The worried well. And what that leads to is that this group who have the means are more willing to invest into preventive care because they perceive their health as being worse. So there is an indication that this perceived health does lead into a certain divide, yes.
One more quick thing about that is that just being a champion again for startup innovation, that even in the startups that are in our program that we're working with, there are startups working on access to healthcare, social determinants of health, health equity. And so if we can just, work that, the startup innovation kind of pipeline in healthcare, we can start to address these. And again, startups are extremely flexible and looking for any opportunity. So they are working on clinician burnout and all this. Anything that will actually have an opportunity and solve real problems, they are working on. So it's just a little.
And it's usually the very simple things. So if somebody needs to go and get a blood test taken because when they went to the doctor that was advised for them, why do they have to take a half a day off of work? If you get paid by the hour, you're not going to do it. It's going to make the health worse. So it's the small things. And again, we say that we're all eventually going to be patients. We're patients today because with each passing day, we get a day closer to death, if you want to look at it that way. But think about the opportunities that we can actually do to change some of these. inequities. If you could use the pharmacy to, because you have a cold or you need to collect something and you need to do a blood test, just think about the simple ways. No one wants to drive 20 minutes or have to take a half a day off of work. It's the small things that will nip it that we need to be thinking about innovating, as opposed to waiting for them to get sick and then trying to work it backwards.
I also think that in addition to all of Dean's startups and lots of startups working on this problem of disparities directly, we have an almost bigger problem of not ensuring that our technologies are designed to actually just make things worse. There's so much bias in the technology that we already have, and there's so many ways that that happens but can be prevented. So one of the things that Health Foundation thinks about is diversity of teams. It's just really important. Investment, totally skewed. We could talk about women in investment, but it's also like people of color or people of less privileged backgrounds, right? We're just not funding. There are great ideas everywhere around the world. We're not funding them. So that's another thing I've been thinking about. And actually, I've been considering running a roundtable for the investors who are now, at least in the US, we have quite a few now who are focused on how do you overcome underrepresentation among startups, right? Because pretty much any founder comes with some experience, potentially lived experience around the problem. Underrepresented founders, I would say at a higher proportion, come with lived experience within the community that they're trying to solve for. And so we have to find ways to do that too. So I actually at Health24, I think I'm going to host a roundtable to help get these people together and think about how to better connect in founders that are not getting financing. Yes. Okay. That's what I'm thinking of doing.
Right. I'm going to draw it to a close. I think I said speaking truth to power. One of the things I'm very grateful for, okay, is that we've actually done some difficult stuff where we don't necessarily all agree with each other, but I think it moves the debate forward. And I think that it's brave for people to express their views, so I am very grateful. So quick round of applause. Thank you very much.